All right. Folks online, can you hear me? Yes? Okay, I'm seeing thumbs up. I'm going to take that as a good sign. Um, my name is Joseph Harris. I'm director of the Global Health Politics Workshop. I want to thank you for joining us from around the world. Uh, this is the first of our series of 4 workshops this fall, 8 total this year, all extraordinary speakers from a number of different fields. And today, we're very pleased to have Dr. Carol Heimer here, eminent sociologist from Northwestern, Professor Emeritus, now also research professor at the American Bar Foundation. Uh, Carol has won awards that span the theory section of ASA, medical sociology section, also was honored with the I'm going to say this run the Versteeg Award for mentoring graduate students at Northwestern. She is one of, I think, still only 2 sociologists to write a global health focused annual review of sociology, and I'm sad that that is the condition that it is, but so pleased that you wrote that. Her work has been cited, I think, at least 10,000 times, many times, many wonderful books and articles. We're very pleased to have her here to discuss her latest and greatest book project that is governing the global clinic, HIV, and the legal transformation of medicine. Please help me welcome Carol Heimer.
All right, so now the challenge of keeping to the time arrives. So thank you, Joe, for that over-the-top introduction, which I think is probably a little bit inaccurate in the representation of you, but that's I accept that. I'll take it all. And I'm really grateful for the chance to talk to you guys, because this seems to me in some ways like the perfect venue for me, because I looked over the list of people who are affiliated with the Global Health Politics Workshop, and it seemed like not just an exciting and impressive enterprise, but also just like the kind of people I particularly wanted to talk to. All right, so I want to start by getting us all on the same page. So I'm going to quickly review a bit of recent history. So in the 44 years that HIV has been on our collective radar screen, it seems like longer than that, I guess, to me. It's gone from being basically an always fatal disease to being considered a chronic disease now. And what this slide suggests is that progress in managing HIV is really kind of a matter of medicine. And a core part of my argument, of course, is that it isn't just that. So panel 1 basically shows the progress of HIV disease as the infected person's immune system becomes compromised with a drop in T cells and the rise in viral load. And at the right side of the second panel, we see the effect of the wonder drugs that people started to be able to take in the 1990s, the antiretroviral drugs combined in carefully worked out regimens. And so their viral loads drop and T cell counts rise after they start taking the medicines, indicating that the disease is under control and also eventually can't be transmitted. And so their immune systems are functioning again. And now, of course, added to this arsenal is the drugs that prevent people from even becoming infected in the first place. Well, in the early days of the epidemic, scientists and physicians first had to figure out what was causing the disease. I mean, it's sort of hard to remember now how much uncertainty there was, except so when you sort of compare with what happened with COVID, there's a same period in when a disease begins of people really not having much clue of what was going on. And during that early period, they could treat opportunistic infections, but they couldn't do anything that actually treated the disease itself. And then starting in 1987, antiretroviral drugs became available. But when they first became available, they were quite a disappointment because they seemed to work and then they would fail. And so it was really only when in 1996, when they started using the cocktail that they referred to then as triple therapy, that they actually began to be able to control the disease. And the scientific findings supporting triple therapy were announced at the Vancouver AIDS conference. And then there was just this rapid diffusion of triple therapy. So that, for instance, within a week, over 75,000 patients in North America had already been placed on that regimen. And it became the norm even in poorer countries, so that in poor countries, people would then talk about, when they encountered a physician who had put somebody on monotherapy or dual therapy, the AIDS physicians would say, oh, that person doesn't know what they were doing. It was that universal. But in fact, even though we tend to describe it as, sort of medical and scientific innovations, those weren't the only things that were required. Social innovations were required as well. And there had to be the creation of a legal framework and a legal infrastructure that helped make this remarkable story possible. So what I'm going to be arguing is that what I call the legalization or the legal turn in medicine and healthcare is actually a complex matter, and that there's a lot of loosely organized pieces that are part of the governance of this system. Much of it is soft law rather than hard law, so it's not black letter law or statutes. A lot of the times it's not treaties, but it's regulations and guidance and policies and even just norms. And not all of it's put out by government. Some of it's put out by other kinds of organizations like insurance companies and NGOs and so forth. But all of this comes together in this complex regulatory system. Okay, so people very commonly basically believe that pestilence and disease lie in the domain of medicine and biological sciences, but in fact, the social arrangements, and in particular, from my point of view, law, have a crucial role to play. So what my book, Governing the Global Clinic, does is to ask how the introduction of these more legally inflected ways of thinking about medicine and healthcare have altered the work of healthcare, and how the effects of legalization vary across sites. So the book also challenges readers to consider the impulse to use law at all, and this is law broadly conceived to include both the hard and soft form, when it makes sense to use legal forms to organize social life and governance and when it doesn't. And to that end, the book brings together these three transformative occurrences from this time period, including the globalization of medicine and healthcare, that instead of sort of referencing only what was happening domestically, people were orienting way beyond the local situation. The legalization of medicine and healthcare, which is a lot of what I'm focusing on here, and the advent of HIV, which sort of accelerated both of the other trends. And I do this in a study of how laws, regulations, and other rules have actually been used. Okay, so illustration that we're part of a global system there, and that there's been technological innovation that we have not all quite managed to keep up with. But anyway, okay. So, but the basic point here is that even though people a lot of times write the history of AIDS as a history of scientific progress and political activism and increasing tolerance, it's also necessarily a history of rules, laws, regulations, guidelines, and so forth, and that we therefore need to study that. And so in the early 1980s, when caregivers began to think that they were seeing something new and they didn't really know what they were seeing, they were particularly concerned about creating systematized bodies of knowledge, because they felt so acutely the absence of anything systematic that they could draw on. So people wanted guidelines then so that they could more confidently diagnose and treat the disease. And they wanted rules of other sorts as well, to give them clarity about who they could and who they could interact with, and what they could do with these people and what they couldn't do, and how they should deal with pressures to honor the rights of patients and the obligations of caregivers. So these laws, rules, guidelines, and protocols and other social arrangements played a crucial role in how the HIV pandemic unfolded. And therefore, we have to consider this history as we're also thinking about the medical and scientific achievements that were part and parcel of what happened. Since our time is short and even shorter after our little Zoom bombing, let me give you some sense of where we're going. So what I want to do today is discuss some of the effects of this legal turn in healthcare using the case of rule use in the HIV clinics that I studied. And I'll explain as we go along what I mean by that. Um, because what was happening was basically a sea change in healthcare in the way that clinical researchers and caregivers worked with the rules. There's two parts to this change. So the first part is about simply the dramatic increase in the number of rules that people were working with. And there's systematic ways we can talk about this, about the number of guidelines that were available, but also the number of organizations sort of helping to track the guidelines, or the number of regulatory bodies that are involved in any particular that people in any particular healthcare site have to interact with. And I catalog those kinds of changes in a lot of detail in the book. But this is not the only part of it that's important, because in addition to that, there's also the way that these rules have changed, right? So it's not just that there's more of them, but they're expected to be used in somewhat different ways. Interestingly, in the United States, a lot of people seem to think that the only kind of law that's relevant in medical settings is law that's about malpractice. So they think that it's about correcting mistakes and compensating patients. And then you press them a little bit, and then they say, oh, yeah, maybe there might be licensing of professionals. And you push them a little bit more, and they say, oh, yeah, there's some legal elements maybe in Medicare and Medicaid. And you push them a little bit further, and they say, oh, yeah, the pharmaceutical companies are subject to some regulation. Yeah, maybe medical research is also regulated. So by now we have really quite a long list of ways that medicine and law are intertwined. And that also should be including things like the articulations at a global level of things like the international health regulations, the Nuremberg Code, the Helsinki rules, the Belmont Report, so forth. And then moving down a notch, the statutes, regulations, and guidance that are national in origin, but have their effects often beyond national borders. And then the medical treatment and research infrastructure and research practices, that have to do with the things about good clinical practice and sponsorship and so forth. So maybe the most succinct way to capture this actually, though, is something that somebody in one of my field sites said, where I often started my interviews with people by saying that I was interested in the mushrooming of rules. And a bit later in the interview, he said he referred to the mushroom cloud of rules. And so I thought, oh yeah, I'm really onto something if my reference to the mushrooming becomes the mushroom cloud. So there's been not only this huge numerical change, but there's been this hardening of rules, so that instead of things that were once sort of norms keep continuing to be norms, they become either standard operating procedures or guidelines or something. And so there's a little bit of extra pressure to follow things exactly. And with the codification of norms into these other harder forms of rules, there becomes pressure for adherence, and then there's new positions and departments created. So there's come to be these compliance bureaucracies that I think a lot of us have experienced. And the people that I studied had a lot to say about that as well. So I've studied this phenomenon of legalization and the legal turn. And to some degree, this follows on research that I did in the past, that in infant intensive care units, where I saw people creating a whole bunch of rules. But in some senses, it's more interesting to study it in the realm of HIV, because it's not just happening within the United States, which was where I'd done my work before, but also it's spread across other countries. And the moving across the boundaries is one of the particularly interesting things. It's also good to study this legalization of medicine, because in medicine, there's a real challenge to updating the rules. And this is something that physicians, I think, have been better at than legal actors, because they've been aware that there's changing knowledge undergirding the rules that they've been working with. And then another thing that I've been interested in is the forward-looking versus backward-looking nature of laws, because I think a lot of people have been dissatisfied with systems of rules that hold people accountable after the fact, but don't sort of encourage them to do the right thing in the first place. So what I want to do now for the next few minutes is talk a little bit about my research sites and methods, and then consider of the negative effects of the legal turn and some of the positive effects. And I will just quickly sort of give you a sense of the stakes that are involved in that, and then go into a couple of examples in considerably more detail. Okay, so positive and negative effects, just to give a sense of the stakes. A lot of the difficulties that I saw in the field sites I was working in come from the introduction of more rules and more inflexible rules, but some of them also arise from these rules being transported from one place to another. And it's particularly when they move from rich countries to poor countries that don't have the resources to implement them. So quickly, just four examples to show that there are both these positive effects and negative effects. The rules about testing, voluntary counseling and testing was the regimen that was used for many years. And the idea of it was that it protected patients from coerced testing. The negative effect of that was that the procedure became very cumbersome, and so it actually reduced the amount of testing that occurred. And I'm going to talk about that example in considerable detail in a moment. Another example would be rules about confidentiality, which can protect patients from many forms of discrimination, but at the same time, they can be very hard to implement, and they may increase the risks that are faced by sexual partners and by caregivers. So both a positive and a negative effect. Clinical guidelines, which are a really important part of the sort of system of rules, are expected to raise the standard of practice, but sometimes they become a ceiling, particularly in fast-moving fields, and particularly when there's issues about the rules becoming part of the legal infrastructure of a state or a province, as they did in South Africa. And also when payers get involved and say, well, we're going to reimburse this thing, but not this other thing. And so then it's hard for medical people to adjust. And rules about the quality of drugs. I mean, we're all in favor of there being rules about the quality of drugs because we want people to get safe drugs. But sometimes those end up working against people in countries where there might be a local manufacturer producing, say, a fixed dose combination. And, the programs that would be supporting research would decide that you could use those local drugs in the studies. And so, even though quality control seems to be a good thing, quality control rules can get misused in that particular way. So it's in part because of some of these negative effects of the hardening of healthcare rules that I carried out the research. And I'll talk a bit about in more detail about some of those examples in a moment. Oops. Okay, so how did I do the research? Over a long period of time is the answer. With the help of a team of graduate students is another part of the answer. So generally, I've been asking how legal tools get brought into medical practice and how they shape the work that doctors and researchers do as they interact with patients and research subjects, how they constrain the aid dollars that are spent and so forth. And often these legal tools, as I said, originate in rich countries, especially in the US, which has been, the 100-pound gorilla in this field, and they get transported to other countries. And sometimes they require considerable modification before they're actually workable. And that modification is extremely costly for the countries that have to do the modification. So it's in the clinics where the legal rubber meets the healthcare road. And so that means that you actually have to watch what people are doing with the rules in order to see what's happening and see what the legal term means. Because the challenge that's posed by the rules varies a lot from one site to another. And also because it's very hard for people sometimes to talk about these rules, not because they're unwilling to, but because some part of it simply becomes background after they've worked with these rules for a long period of time. So we did, my team and I, a lot of background interviews just to sort of get the lay of the land and to know what guidelines and policies people were working with. So we started doing those in the US, but then in each successive country, we did more of them because we needed to know their terrain there. We did interviews and ethnographic observations in the US and in other countries. And the data collection, the interviews and observations were focused on 5 HIV clinics. 2 of the clinics were in the US, and 1 each in Thailand, South Africa, and Uganda. So I was looking to use a mix of rich and poor countries. So there would be variability in the resources that were available, but also variability in the extent to which the people in the clinic conceived themselves to be rule makers versus people on whom rules were imposed, more or less. And much of our work was therefore focused inside the clinics, but we also followed people as they moved outside the clinics. For instance, to attend conferences and give presentations, going to training sessions, going to user group meetings, and so forth. So as I mentioned, interviews are important in this kind of work, but the ethnographic observations are absolutely crucial. And it's exactly because of the kind of thing that Mary Douglas talked about rules that have been naturalized versus ones that don't seem yet natural to the people in the clinic. So if you only interviewed people, you would be hearing about the ones that hadn't been naturalized. You would hear about the irritating ones, and all the things that were part of the legalistic background you wouldn't hear about. But me going in, it all looked unnatural. So I could see what they were doing and then ask them about those things in a way that I would never have had the wits to do if I was just doing interviews. And then we also gathered a lot of documents. We got documents about the written guidelines and policy statements, training documents, the forms that people were actually using as they did their work. So it sort of tells you how the law moves into the daily practice of the clinics. And then we systematically coded all this data using Atlas TI, but we also endlessly read and reread the interviews, which I think is much more important than anything you get from Atlas TI. Okay, I can't show you pictures of the clinics for confidentiality reasons. The 2 US clinics, one with insured patients and one with indigent patients, would look like pretty much normal medical settings in the US, right? No big deal. In those 2 clinics, the staff members found the rules annoying. In fact, they found them very annoying, and especially the accounting rules. And especially in the clinic with indigent patients, they would tell you a lot about how annoying the Ryan White rules were. In the clinics outside the US, whoops, that's not what we intended to do. There. I can at least show you a little bit about sort of the area around the clinics, which tells you something about um, uh, the level of development. So one of these clinics was in Thailand, and this picture shows the bustling streetscape near the clinic. And the clinic was nearby inside a compound with walls around it. And there were several large, well-maintained buildings that housed the clinic. And Thailand is a middle-income country that also happens to have a relatively well-developed pharmaceutical industry, which is quite important for the research. And in the Thai clinic, staff members were especially annoyed about rules about which drugs could be used in clinical trials. They had a fixed dose combination. They wanted to be using it for a variety of reasons in some of their clinical trials, and the rules of American funders prohibited that. You could only use American brand name drugs. Another country that I did research on was South Africa in Durban. And this is a picture of the road connecting the main hospital to the HIV clinic. And as the slide suggests, there's been a drop down a notch in the level of development. It's still clearly a lot of commerce going on, paved streets, cars, well-maintained building. So it's a middle-income country, but one that has massive inequality, a less adequate pharmaceutical industry, a very high rate of HIV infection, and for a time, a president who stalled on providing treatment by denying that AIDS, the disease, was caused by HIV, the virus. The workers in this clinic spent a lot of time adjusting clinical guidelines to fit the needs of their patients, because guidelines that were developed in the US for treating gay men don't actually help you very much to treat pregnant women or to treat children. There were also issues with the national regimen, which contained a drug that they were very worried about because it had a serious side effect, and they were worried that the national government was not going to be flexible about allowing them to switch people off, and so that they were going to be losing patients on that. And they were worried about the rules about confidentiality and consent, and especially in cases of treating children, because the rules are developed for, with the expectation that you're going to be seeing married couples, both parents still alive, and it's going to be clear who can give consent to treat the child. And in this case, a lot of times, those parents were no longer available, or one parent was available and not the other one. And so that created big headaches for them. And then, whoops, I keep going backwards here. And this is in Kampala, Uganda, in the vicinity of the clinic. It shows a characteristic pattern of that you see in poor countries where there's well-built establishments. You can see some in the very background at the top of the slide. And further up the hill even more. And so these nice buildings are cheek by jowl with the living quarters of people who are utterly destitute. There's cars, but there are shacks. There's dirt roads, but there's also some paved roads. And in this kind of location, it was very hard for people to follow the rules as they were doing the medical care, because the routines of rich countries just don't work very well when you don't have a reliable water supply or a reliable provision of electricity, when the stockouts of medicine, when the lab facilities don't operate around the clock, and so forth. The clinic buildings here were in a compound with some very new buildings that had dramatically improved working conditions. But some of the work was also carried out in a building that an American publication referred to as a shack, which seemed to me an exaggeration, but nevertheless, it shows sort of how Americans sometimes look at these kinds of situations. So Uganda is a very poor country, has a high rate of HIV infection, and essentially no pharmaceutical industry. But what Uganda did have was a willingness to admit that HIV was present in the country, even at the highest levels of government, they admitted that, and to invite other people in to help them deal with it. But it was extremely challenging to make the rules work there. Different patient population than the rules were written for, lots of women and children, lots of poverty. One of the most interesting episodes of my field work came in sitting with a physician who was training physicians from around Africa to deal with HIV. And we were going through the guidelines and talking about a particular case and walking through what you should do to treat this woman who was also pregnant, had HIV, and had TB as well. And wanted to be pregnant. So, do an abortion was not really an option in this case. And as he's walking through the guidelines, all along the way, he's saying, well, you look at these guidelines and you think you should do this, but here in Uganda, we can't do that. You might think this is what you're seeing, but you have to consider that there's this other condition that's altering what you're seeing. So you have to do this. So at every step along the way in trying to implement the guidelines, he had to make an adjustment. So this was sort of graphic evidence of the limits of standardization, which is what everybody has been trying to do there. Okay. So what is it then that legalism actually entails? In HIV, the legal term involves transporting legal forms across two different kinds of boundaries. So on the one hand, it's about crossing a disciplinary boundary from law to medicine. So it's taking forms of interaction that are common in the law and imposing them in a world that has worked with a different set of understandings of how you use rules. So it's crossing from law to medicine. And that's both about putting in place more rules, but it's also about working in a more lawyerly way with those rules, that they're more often now conceived to be prescriptions rather than guidance, and that discretion, which has traditionally been rather low down in the system in medicine, moves up a little bit. But secondly, it's also about a geographic and political boundary crossing. So it's taking rules that were created in the global north and moving them to the global south. And that's happening for two different reasons. First is because the science was initially done in rich countries, and the guidelines were written in those rich countries about men, and then and adult men, that is, and then they have to move to places where the people being treated are often women, often children, often pregnant women, as well as men. But it's also about rules that come because the funding for a lot of this research and treatment comes from rich countries, and especially from the United States. And with money always comes the rules about accountability. Okay, just very, very quickly, I don't want to dwell on this, but this is, I mean, you could say this is the obligatory, you can't read this slide, right? But what I just want to show you here is the complexity of all of this. So there's these international treatment guidelines that are created both by international professional bodies, sometimes by NGOs like Médecins Sans Frontières. And then there's national treatment guidelines, and then there's clinic treatment guidelines. And so there's a translation process that's going on at all of these levels. And as you move down that table, they become, the rules get translated, they also get hardened so that by the time they arrive at the clinic, these are things that you have to do, right? And then because a lot of those rules are so complex and described in such voluminous tomes, hundreds of pages long in many cases, those tomes are treated as a reference book, right? Nobody's going to be sitting there reading the 200 pages about how to treat men and adolescents. And then doing the translation from that. So they end up using these kinds of tables that are basically a recipe that's distilled into a chart. And then sometimes people boil it down even further. So they'll take something like this table and they'll put it in a set of guidelines that they've rewritten specifically for their clinic. And there was one person in South Africa, for instance, who particularly enjoyed this and was, doing rewriting the guidelines into clinic level guidelines to be stored in each of the treatment rooms, both for HIV and for TB. And then this is where you can see the hard law showing up in soft law documents. So this is a flow chart, but right there in the center, there's a square that says registered health professional prescribes AZT plus CD4 count. Okay, so registered health professional is a legal category, right? And you see these kinds of things all the time. And it's not just in something like that where they're talking about a doctor, which is something that we recognize, but in lots of these kinds of flow diagrams that people are using in clinics, there would be these sort of quasi-legalized things with lots of different kinds of occupations. And so there you'll be told that it's this particular kind of person who has to do the consent process, or this particular kind of person who has to do the testing for HIV or whatever. And so what had become flexible workforce becomes a much more rigid workforce. And, even though we kind of intuitively understand the regulation of healthcare providers, it's not quite so clear to us why there's such intensive regulation of who can go through a process of counseling somebody before an HIV test. Okay, so I want to talk now in more detail about the harms of some of these rules. And the example I want to use is HIV testing. So in the beginning, when HIV testing was first developed, um, there were a lot of disputes about testing, and in particular, there were questions about how much counseling should go along with it and who should have access to the results. And some of the disputes arose because when the tests were first developed, they were being used by blood banks, and the blood banks were not releasing the results to any of the people who had been tested. And so, for instance, in New York, the AIDS activists were saying you shouldn't get tested because there's nothing in it for you at all, and besides, there's nothing that comes from knowing about it because there's no treatment available anyway. So partly in response to this, people developed this set of procedures that solidified into the VCT regime. which is voluntary counseling and testing. And so it involved pre-test counseling, testing, and then post-test counseling. But then immediately there were difficulties about implementing this. So it was hard enough in rich countries like the United States because you had to train up all of these counselors. But in lots of other countries, there weren't people available to do the counseling. There wasn't privacy to do the testing. And so the testing became this big bottleneck. So for instance, in South Africa, I heard about people queuing up at a football game, soccer game, to be tested. And there were hundreds of people who queued up and they couldn't test all of the people because they just didn't have enough staff members to do it. I also heard in South Africa about how, and this was in a village situation, about how what's the point of all of this confidentiality anyway? We all know has HIV because if you go in for counseling, everybody has the same length of pre-test counseling. Everybody has the same test. Some people have a long post-test counseling session. Some people have a short one. Guess who's HIV positive? We all know. So what's the point of all the confidentiality? So then over time, as treatment became available, then people decided that, well, maybe we should be starting to treat this as a more routine testing situation. Lots of medical tests are done on a routine basis. So we should have RCT instead of VCT, routine counseling and testing. It took years, a couple of decades, to de-implement the testing regimen. This is deeply, deeply consequential because at the time, and we have a pretty good metric for thinking about this, because UNAIDS episodically announces goals in its campaign to end the pandemic. And there was a period when it was 90, 90, 90, then it became 95, 95, 95. And the idea of 90, 90, 90 was that 90% of the people who are living with HIV should be tested and know their status. Among the people who test positive, 90% of them should get put on treatment. And 90% of those people should receive sufficiently good treatment that they become, their virus is suppressed. So they become healthy again and they can't pass it on. But what ended up happening instead was that rather than 90, 90, 90, what was actually achieved was 54, 76, 78. 54% of people who were HIV positive, who had HIV, ended up getting tested. 76% of those people got on treatment, and 78% of the people on treatment have achieved viral suppression. So the result of that is that where 90, 90, 90 would have meant that 73% of all of the people who had HIV would become virally suppressed. What ended up happening instead was only 32% of people who had HIV were virally suppressed during this period. And that's a lot because of the weakest link at the beginning, the testing regimen, right? And so in the words of Edwin Cameron, Justice of the Supreme Court of Appeal in South Africa, and himself HIV positive, the testing rules had become a barrier to diagnosis and treatment and a source of risk and harm. So the effect of the VCT rules in prolonging the epidemic are very, very substantial, and I would suggest more substantial than South African denialism, which resulted in 330 excess deaths and 35,500 excess infant infections. Why is this more consequential than AIDS denialism? Well, first of all, it's because VCT was a universal routine. It was being used all over the world, not just in South Africa. And also because VCT had been legalized, that is turned into hard law in a lot of cases, adopted as formal law in many countries, it was hard to undo. Whereas AIDS denialism was actually easier to undo. So AIDS denialism went on for 1999 to 2008, but the de-implementation of the VCT regimen took a lot longer. The last state in the United States to end the VCT regimen was Nebraska in 2018. So this is just one example, and there are plenty of others of ways in which introducing more rules and hardening these rules has had some really negative effects. Temporarily banning the offering of better care to prevent mother-to-child transmission in South Africa. Reimbursement rules have had huge effects. Reluctance to participate in a rollout program because of anxiety about the rigidity of rules about transferring people off a regimen that wasn't working. Not wanting and there's many of these. The VCT situation isn't really anomalous, right? It's just one that's easy to show what the huge effect is, because we have that handy comparison with 90-90-90 and what it should have achieved. Okay, so why do we have these negative effects of more law in clinic life? Well, first of all, clinic staff are trained in medical matters, not in the legal use rules. Most of them don't have any legal training at all. And so they have trouble when they confront these rules, they have trouble sorting out exactly what they should be doing. And there's linguistic signaling that goes along with this. So for instance, when people talk about the kinds of knowledge that they've acquired and the kinds of guidelines they're following because of their professional training, they use the words like you always, you must. When they talk about the ones that seem to be foreign impositions, that they don't really understand where they come from or why they have to do it, they say what they want. So then the increase in the number and formality of rules makes it hard for people to stay on top of these rules. That's that mushroom cloud part of it. Okay, so people are very uncertain about where the rules come from because lots of times some of them are formal law, some of them aren't, and they don't know, so they don't know what they're supposed to do. And when they're confused in this way, it a lot of times means that they delay as they try to sort it out. And sometimes within healthcare situations, that can be extremely consequential because drug resistance develops, or people say who've had needle stick injuries become infected while they're waiting to sort it out. Okay, so let me talk then just briefly about some unexpected benefits of rigorous IRB rules. And some of you know that I'm not a fan of some of the IRB rules, but sometimes they have positive effects. So it's one of the objectives of my research then has been to figure out what makes those positive effects more likely. Rules about the ethical conduct of research are very prominent for many of us and very irritating to a lot of people. And they're a very good example of legalism in the medical world. So much so that I refer to them sometimes as wicked ethics in a paper that I wrote on IRB rules. So I want to talk briefly about a situation with ethics review that led to a delay in a clinical trial. And this was because there hadn't been an adequate provision to continue to supply the test drugs beyond the end of the trial. And the context for this is about the Helsinki rules, which added pressure for more universalism in clinical research. And basically the idea is that when clinical trials began moving outside rich countries like the US to poorer countries, this was happening partly because there were more drug naive patients available. So it was easier to do the clinical trials without having interference of people having already receiving a lot of drugs that would make the results confusing. But it was also cheaper to do the clinical trials in poor countries. And so what people became worried about was the ethics of doing research in poorer countries, because part of what was going to be happening was that what was being provided to the patient's research subjects there was less than they would get in richer countries. So there was a concern about inequality and exploitation. So there was a clinical trial that was just about to begin for antiretrovirals, and the research subjects were eager to participate in it because they were worried about succession. Okay, so succession there was, the parents have children, they're worried about dying and there being nobody in place to take care of their kids. So having an extra year of life as you get these experimental drugs means you have more opportunity to make some provision to have somebody to take care of your children. It's crucial. The pharmaceutical companies were reluctant to continue to give drugs beyond in the post-trial period, even though they would have done it in rich countries. And there were two IRBs involved because it was a collaboration between a Ugandan clinic and an American university. And the Ugandan IRB, having a local perspective, said, fine, do the research. The American IRB said, hell no. Um,
Mhm.
and so there's this protracted discussion during which people are not getting the drugs. And eventually the drug company caved and agreed to provide access to drugs for a longer period of time. So the result is more generous funding. It only came about because there was all of this discussion. And this discussion only happened because of this extremely legalistic situation. But note here that the two IRBs had very different strengths, right? So the American IRB was more likely to be able to speak truth to power, and it was more effective in pressuring the drug company. The Ugandan IRB took very seriously the concerns of the Ugandan people who were so concerned about arranging succession for their children. You needed both of these in the discussion. But the general point is that the universalism of these rules encouraged people to rethink moral issues and forced them to have a deeper consideration of what they actually owed their research subjects, something that wouldn't have happened but for all the legalism that was involved here. And again, this is not a unique example. There are other examples of things like treatment contracts that get put in place in poor countries that are part of what I refer to as a ritual surplus where they're showing how much they're complying. Yes, we're complying. See, we do all this extra stuff to show you that we're complying, and this occurs in testing. It occurs in consent processes for research, and it occurs in treatment contracts where people have to sign something saying that they know that they're going to have to take these drugs for life, and they promise to take them faithfully and all that. And then it turns out nobody's providing the drugs, right? But because this is a one-sided contract, then, the people who might have been able to provide them the drugs, the researchers, start to feel a little nervous about this, and a dialogue happens again partly because of the legalism of the treatment contract, right? Um, and um, and so they create extra resources that would not have been there otherwise. So the positive effects of moral law in clinical life basically are about law acting as a language for discussing what we owe each other. So there's a lot of times hard science that gets turned into these guidelines that make it really, really clear what's appropriate and necessary treatment. And that makes it hard not to give people what we know is what that they actually need. But that's not by itself enough. We also need to ensure that there's more people at the table to represent the different kinds of interests that people are experiencing in their daily lives. Um, and that sometimes takes a long time to unfold, but nevertheless, some of the requirements of the rules make that more likely to happen. So what soft law does, soft law with discussion here, is that it helps ratchet up universalism and commitment to fair provision. And so in effect, what's happening here is that legalized accountability then slowly becomes transformed to look something more like legalized responsibility that is having that forward-looking aspect to it. Okay, quickly to conclude, hopefully with no more Zoom bombing. So to answer the question my research poses, what are the ultimate effects of the legal turn in HIV clinics and in healthcare more generally? Well, to start off with, people working in these situations definitely feel burdened by that mushroom cloud of rules. And they interact with these rules not always in the ways that are expected. I mean, they're not just adopting the rules, they're translating them, they're sorting them out, they're building routines around them, they're producing summaries of them, they're altering the guidelines and standard procedures to adjust to their own situations. Sometimes they're actually trying to modify laws. For instance, in Uganda, they spent several years modifying the statutes about who could consent for the treatment of children. And sometimes when the challenge is just too great, they're stalling, unfortunately. So yes, more rules and laws can improve the quality of care. That is, they put in place a treatment floor and they may help regulate the quality of drugs. They may insist that caregivers be well trained. They may systematize research processes. But they also often harden rules in ways that make it hard for professionals to do their work. This is, in effect, the double institutionalization that Paul Bohannon talked about many years ago, And that is, since if you double institutionalize it the wrong way, that you end up then creating confusion because of different traditions of rule use in law and medicine. But the second effect is also important. It can create dialogue about what we owe each other, and sometimes that dialogue does come with extra wrangling and delays, even though it leads to good results. So this examination of the 5 clinics experience suggests a little bit of what we might need to get the more of the positive and less of the negative. First, we need more attention to context and respect for the context, so that, when we're transporting rules, we say, well, what is it about this context that is going to make these rules difficult to implement? And it might be something about the endemic diseases. It might be something about the resources that are available. And some kinds of rules simply will need to be updated more frequently. So this is a strength of medicine as compared to law, because medicine has traditionally updated as new knowledge came in. Thirdly, we need more humility about the projects of other professions. In healthcare settings, doctors' ways of working with rules really are sometimes better than lawyers' ways of working with rules. And fourthly, we need dialogue. We need to foster dialogue about what people owe each other. And that needs to also be less about holding people accountable and more about trying to figure out how to create commitments to do the right thing. What I was going to show you is my book cover. And the reason I was going to show it to you is because the University of Chicago Press said that if you use UCP new at checkout, then you can get a 30% discount.